welcome to our webinar, GLP-1R, A New Frontier in Glaucoma Treatment. My name is Cynthia Steel, and I am the Chief Scientific Officer here at Glaucoma Research Foundation. And now I am pleased to introduce Dr. Qi Cui, who completed her MD PhD at the University of Rochester, her ophthalmology residency at UC San Francisco, and glaucoma fellowship at Wills Eye Hospital. Dr. Cui specializes in the diagnosis and management of glaucoma at the Qi Eye Institute, where she performs both glaucoma and cataract surgeries, including minimally invasive glaucoma surgery. She also leads a lab focused on understanding glaucoma pathogenesis and developing new treatments. Her recent work highlights the potential of GLP-1 receptor agonists, which are commonly used for diabetes and weight loss, as a promising therapy to protect retinal ganglion cells. In 2021, Dr. Cui received a GRF Schaefer grant that supported this work. Please join me in welcoming Dr. Cui.
Thank you for that wonderful introduction, Cynthia. I will always be grateful to the Glaucoma Research Foundation for giving me the seed money to fund some of this work. Thank you for the invitation to speak here today. And today I'm going to be talking about glucagon-like peptide 1 receptor agonist and its potential as a new treatment for glaucoma. I do not have any relevant financial disclosures. And here's a list of my current funding sources. So over the past few years, a class of medication called glucagon-like peptide 1 receptor agonist has really entered the public consciousness. Here's just a list of all the different news articles that have been out about these medications. The names for some of these medications are Wegovy and Ozempic. The medications have really been talked about, in publications, both with respect to its protective nature and also some of the downside of its use. So what are GLP-1 receptor agonists? So GLP-1 is incretin hormone that regulates blood glucose, weight, and satiety. And that is secreted by our own gastrointestinal tract. So agonist for the receptor was developed from the saliva of the Gila monster, which is a large lizard that's found in the Sonoran Desert, to treat type 2 diabetes. The first receptor agonist was FDA approved in 2005, and both sub-Q and oral formulations are available for these class of medication. It has become quite popular, partly because of relative decreased incidence of side effects, and also its less frequent dosing, often only once a week. It has also been found to offer additional protective benefits towards cardiovascular death, lowers serum lipid, lowers diastolic blood pressure, and offers renal protective benefits. It's been approved for weight loss as Wegovy in 2021 and for cardiovascular protection in 2024. And more recently, earlier in 2025, for treating chronic kidney injury and for also liver injury. More recently, a dual receptor agonist, the GIP-GLP-1 receptor agonist tirzepatide, brand name Mounjaro and Zepbound, was approved for diabetic treatment and for weight loss in 2022-2023. So how do these medications work? Well, as we've already talked about, GLP-1 receptor agonists are incretins, and that means it improves insulin secretion, thereby improving glycemic control in response to oral glucose ingestion. As we know from the work of Adriana DiPolo and others, insulin topically applied into the eye has been found to restore retinal ganglion cell function and connectivity and promote visual recovery in models of glaucoma. Largely based on this work, there are currently at least 3 clinical trials looking at topical insulin for treating glaucoma. In addition, my lab, as well as others, have shown that GLP-1 receptor agonist also decreases neuroinflammation. To understand how this happens, it's important to take a step back and talk about reactive astrocytes and the role it plays in retinal ganglion cell death. So astrocytes, as we know, is an important class of support cells within the central nervous system. It forms the blood-brain barrier and the blood-retina barriers, and they also change form in response to local injury and disease. A form of reactive astrocytes called C3 positive reactive astrocytes has been found in multiple neurodegenerative conditions, including Alzheimer's, Huntington's, and Parkinson's diseases, and as I will show later, in glaucoma as well. These C3 positive reactocytes have been found to be neurotoxic to retinal ganglion cells. Specifically following optic nerve crush, microglia, which is another form of support cell in the central nervous system, releases cytokines, which are small molecules, to induce astrocytosis, which are these reactive astrocytes. And inhibition of these small molecule cytokines prevents this reactive astrocyte transformation and rescue retinal ganglion cells. So NLY-01 is an experimental GLP-1 receptor agonist with a long half-life, and it has been shown in other publications to prevent C3 positive astrocyte transformation by specifically reducing microglia release of these cytokines. And this has been neuroprotective and shown to improve motor symptoms in models of Parkinson's. Given that NLY-01 reduces C3 positive reactive astrocytes, and C3 positive reactive astrocytes causes retinal ganglion cell death, we sought to examine whether GLP-1 receptor agonists such as NLY-01 may also be protective in a mouse model of glaucoma. So we elevated intraocular pressure inside the eye by injecting microbeads into the anterior chamber of mouse eyes. In our hands, a single injection of microbeads results in elevated intraocular pressure for about 6 to 8 weeks. Afterwards, we treated these animals with sub-Q injections of NLY-01, and we found that it indeed decreases the release of these cytokines by microglia and macrophage within the retina. In addition, it also reduces reactive astrocyte formation within the retina as well. Most importantly, it rescues retinal ganglion cells in our mouse models of glaucoma despite persistently elevated intraocular pressure, and the rescue approaches 100%. And the rescue, as we can see here, both occurs structurally, meaning it maintains the structure of the retinal ganglion cells, but also functionally, meaning it maintains the electrophysical activity of the retinal ganglion cells as well. In addition to this experimental GLP-1 receptor agonist, we also looked at other GLP-1 receptor agonists that are on the market today, including liraglutide. And we found that regardless of the GLP-1 receptor agonist use, they all provide some neuroprotection when it comes to retinal ganglion cell somas and axons of the optic nerve shown below. The data I've shown so far are all in animal models of glaucoma. Here we show that the C3 positive reactivity is also present in human glaucoma, and these are human eyes. Given that GLP-1 receptor agonists have been used for many years, over 15 years now, to treat diabetes, we asked the question, is it possible that GLP-1 receptor agonists may also alter glaucoma risk in diabetic patients? We looked at this question using a de-identified medical claims information database from the large US insurer Optum. We looked at adult patients older than 18 years of age who were initiated on a GLP-1 receptor agonist, and we matched these patients to patients started on a different class of diabetic medication on age, gender, race, and date of medication initiation. And we found 1,961 cases and over 4,000 controls. What we found was that indeed in these sort of matched case and control populations, GLP-1 receptor agonists are associated with about a 44% risk reduction for a new diagnosis of glaucoma or glaucoma suspect. When we take away the glaucoma suspect definition from the outcome, we found that the protective effect is even greater, greater than 90%. Since the publication of our study, there have been multiple other studies using large databases showing the protective effect of GLP-1 receptor agonists, specifically using a global health data network, the Trinetics data network. GLP-1 receptor agonist was found to lower the incidence of glaucoma and the need for treatment compared to metformin. Using a large Danish cohort, GLP-1 receptor agonists were found to be associated with a lower risk of glaucoma compared to second-line diabetic medication. In a large cohort of Taiwanese patients, GLP-1 receptor agonists were found to be associated with a lower incidence of glaucoma in diabetic patients, and this association was more significant in younger patients. And finally, this protective effect was found in non-diabetic patients as well. Once again, using Trinetics, GLP-1 receptor agonist use was associated with reduced glaucoma risk in weight loss patients at 3 and 5 years. In addition to just looking at the protective effect of GLP-1 receptor agonists, we also asked the question, is it possible that these medications may also lower IOP? The reason we thought to ask this question is because we know GLP-1 receptor agonists are used off-label to treat idiopathic intracranial hypertension. And it does this by decreasing the secretion of CSF within the brain. The mechanism behind CSF secretion and the mechanism behind aqueous humor secretion within the eye are the same. So GLP-1 receptor agonists, in fact, act within the ciliary body to decrease aqueous humor production. It could also decrease intraocular pressure. So we looked at this question using the University of California data warehouse, which contains IOP records of over 200,000 eyes. We looked at patients who were initiated on a GLP-1 receptor agonist versus a new diabetic medication. And we found over 2,000 eyes with at least pre-exposure to the medication and one post-exposure intraocular pressure record. And what we found was that GLP-1 receptor agonist use were associated with a small but significant decrease in intraocular pressure. Now, this intraocular pressure decrease, as you can see here, is less than 1 millimeter of mercury. So it's possible that this is not, in fact, clinically significant. In subgroup analysis, however, semaglutide and liraglutide, which are the two most commonly prescribed GLP-1 receptor agonists, were associated with a significant change in IOP. So NAION risk associated with GLP-1 receptor agonists. So here what I have is the Hathaway et al. Paper that was published in JAMA Ophthalmology in 2024. And this is a retrospective matched cohort study using neuro-ophthalmology data at a single academic institution and showed an elevated risk in the user semaglutide for NAION. Since the paper was published, there has been a number of retrospective database studies all examining the same question. Is there an association between NAION risk and semaglutide? And two of these use the Trinetics database network that I had talked about. And you can see that at least 4 of these studies shown here do suggest that there is no increased risk in NAION in patients who received semaglutide for treatment of either type 2 diabetes or obesity. In comparison, 2 separate studies, both of which are conducted in Scandinavian countries, show that there is an increased risk in type 2 diabetic patients who are prescribed semaglutide. So what can we do to sort of make sense of this contrasting data? Well, I think looking at this specific study from Simison et al., which is shown here at the very bottom of the slide here, we can sort of look at an absolute risk increase as opposed to a relative risk increase in this paper that was reported as opposed to some of the other papers. And this absolute risk increase as reported in this paper is actually quite small. Is only one event per 10,000 person years. So what this means is that in certain populations, there may be an elevated NAION risk, but this risk may in fact be quite small. So what are some of the take-home messages from our talk today? GLP-1 receptor agonist has been found to increase insulin secretion and exert an anti-inflammatory effect in the central nervous system. And GLP-1 receptor agonists reduce macrophage microglia activation and astrogliosis and intraocular pressure elevation. This has resulted in both structural and functional rescue retinal ganglion cells, as we've shown in mouse models. The use of this medication is associated with a lower risk of glaucoma in diabetic and non-diabetic patients and reduced intraocular pressure. And current literature is quite mixed on whether GLP-1 receptor agonist use is associated with NAION. However, the absolute risk, as I've shown based on that one paper, remains quite low. Planning for a clinical trial to examine the efficacy of GLP-1 receptor agonists is underway and is ultimately necessary to establish these medications as the disease-modifying therapy for glaucoma. Thank you for your attention, and I apologize for that technical difficulty. None of this work would have been possible without everybody listed here, which are members of my lab and also my collaborators. And once again, I would like to thank the Glaucoma Research Foundation for providing some of the seed money to support this research. Thank you so much.
Thank you, Dr. Q. That was wonderful and very, very interesting and very pertinent given how every other commercial I see on TV is for a GLP-1 receptor agonist. So very interesting. Thank you. We have received a lot of questions, so let's just get right to it. First question is, must the GLP-1 be injected directly or given topically to the eye? Or can it give benefit to the RGCs when taken systemically, like for diabetes?
That's a great question. Most of our studies, because they're retrospective and looking at diabetic patients, are looking at GLP-1 receptor agonists given systemically. So none of it was really given topically other than some of our mouse studies that I've shown. So this suggests, based on existing evidence, the protective effect of GLP-1 receptor agonists all come from systemic administration.
Great. Have there been any controlled clinical trials of GLP-1 receptor agonists for glaucoma, either through oral or topical administration?
There's one underway right now in Denmark. So my understanding is that they're still currently recruiting. It's funny you should ask that because I am looking to establish such a clinical trial in the United States right now and working hard on that.
So we will wait with bated breath for those results. What was the magnitude of the protective effect against glaucoma in the observational studies of patients on GLP-1?
Yeah, it's variable. I think the highest protective effects was what we showed in our study, which is over 90%. That's an outlier. Most of the other protective benefits range anywhere from 25 to 30% to 60+%. So I would say, if you think of GLP-1 receptor agonists based on existing studies as basically halving the glaucoma risk, that's a safe way of thinking about it.
Great. What doses or dosing strategies are being studied or appear most promising?
So that is a really good question. And right now we don't know the answer, right? So most of the data that we have are based on these retrospective database studies, which does not give us the dosing information. All it tells us is are patients on these drugs for diabetes or for weight loss.
Mhm.
The clinical trial that is happening right now in Denmark is using a oral formulation of semaglutide, and it's quite a small dose. I think it's 0.5 milligrams per day or something like that. So it remains to be seen, whether that dose is sufficient is sufficient for us to see an effect in the protective effect of glaucoma.
Mm. What led to the discovery of GLP-1 receptor agonists as potential treatments for glaucoma?
Yeah, in our case, it's really, happenstance, I want to say. So we saw the paper where they looked at NLY-01, which is, as I mentioned, experimental medication that is within the GLP-1 receptor agonist class. And we saw that it's protective against these neuroinflammatory changes within the eye. And we wanted to see whether these neuroinflammatory changes also occur in glaucoma, just because it's been shown in so many other neurodegenerative conditions, such as Alzheimer's, Parkinson's, and frontotemporal dementia. And we know those neurodegenerative conditions share commonalities with glaucoma. So we basically just set out to see, is this the same thing? Is this class of medication going to do anything in our mouse model? We're happy to see that it did. And so that's sort of what gave us an idea that these medications may be more effective in glaucoma patients than we would have initially thought.
Just as a follow-up, how does NLY-01 differ from any of the commercially available treatments? Or did you consider using some of the commercially available treatments but decided on NLY-01 first?
Yeah, so we initially used it, like I said, based on that paper because the
Mhm.
paper showed the effectiveness in LY01. So we just sort of replicated it essentially. Since then, we have looked at other commercial GLP-1 receptor agonists, and they show a similar protective benefit. In fact, in our examination of liraglutide, it suggests that liraglutide may be slightly more protective. Mechanistically, they all work similarly in the sense that they all attach to the receptor and they have their downstream protective effects all generated through the activation of the receptor. So that on its own, as far as we know, is not all that different.
Really interesting. What is your perspective on whether GLP-1 RAs may help patients with normal tension glaucoma? Could it reduce intraocular pressure or could it be doing something different?
Yeah, so I think it remains to be seen, honestly, right? So none of these studies have actually specifically looked at normal tension glaucoma. One of the reasons being that when you use a retrospective database, it's really hard to tease out, do these patients have normal tension glaucoma versus, high tension glaucoma that just does not have any elevated intraocular pressure documented in their chart. So that's really difficult to tease out. Um, from what I know about the mechanistic effects of GLP-1 receptor agonists, there's no reason to suppose that it would not work for normal tension, right? So we
Mm.
showed that it lowers intraocular pressure, but the pressure lowering effect is relatively minimal, at least in our cohort. So it's possible that that may not be the dominant mechanistic reason why these medications work in glaucoma. It may actually be the insulin sensitizing effects, through its incretin activation, or it could be related to the anti-inflammatory effect that we've demonstrated. Both of
Mm.
which, we know can happen in normal attention glaucoma, so there's no reason to suppose that it would not work.
Okay. Um, for a person with low blood pressure, are GLP-1s okay to use?
I know I'm not going to pretend to be a super expert when it comes to all the side effects of GLP-1 receptor agonists. So I'll answer that question with just a little grain of salt. But as far as I know, there's no significant reduction in blood pressure, in systolic blood pressure in patients who take GLP-1 receptor agonists. But, I could be wrong.
We have a couple of patient-specific questions for you. So one is asking, could a 95-year-old patient realistically benefit from potential GLP-1R therapy for glaucoma? Or what about a person who's already in the severe stage? Or has any of that been even elucidated yet?
Yeah, so we are actually trying to conduct a retrospective database study to specifically answer that question. And the question really is, if someone already has glaucoma, is there any benefit of taking GLP-1 receptor agonist in thinking it would decrease progression? And the difficulty in answering that question is really just looking for data, for databases that has visual field and OCT data, right? That's really what tells us whether there's progression moving forward. And so we're trying to combine a lot of databases from a lot of large academic institutions to basically answer that question, to give us enough power to answer that question. So this is a long roundabout way to say, stay tuned. We are hoping to have that result relatively soon, but it's been a long process. And that will hopefully tell us, should we be putting patients who have glaucoma, whether it's mild, moderate, or severe, on GLP-1 receptor agonists.
Has any of that work been done in animals yet? Like using a mouse model of glaucoma, for example?
Yeah, so it's a little bit harder to do in animals. If I'm understanding your question, Cynthia, you're asking, what if we give these medications to the mice after they've already had some retinal degeneration? Is that
Hmm.
right? Yeah.
Or any
So
of the
we have
genetic models, the transgenic models?
Yeah, yeah. So we have done that using both the microBee model, which is the data
Mhm.
I showed, and the DBA2J model of glaucoma,
Ah,
and they're protective in both. It's a little bit
good.
hard to tease out, is it protective because, we started giving it to them early in the disease process, or would it be protective if we give them later? Just because those models are a little bit inconsistent and it doesn't exactly recapitulate POAG in humans.
I see. I see. For our audience, would you mind quickly elucidating the difference between a prospective and a retrospective clinical trial? We've been talking a lot about retrospective trials. Maybe just make that distinction.
Oh, yes, I'm sorry. So retrospective studies just means that we're using data that's already there and we're sort of pulling results from those data. So we're not following patients moving forward, or we're not, putting them on different interventions and seeing how they respond to that. That will be a prospective study. So moving forward versus moving backwards.
Yep, yep, makes sense. Um, a patient wants to know they have POAG in the left eye and they've been taking Zepbound for weight loss. One of the contraindications for Zepbound is diabetic retinopathy. And in fact, some doctors won't prescribe it for patients who already have eye issues. So this patient is wondering if a reduction in IOP has been observed in patients taking some of these GLP-1s specifically for weight loss.
Yes. So in addition to our study, there have been, I don't know if any of it's published, but there has been a lot of anecdotal evidence. So this is from me talking to people of various conferences suggesting that their patients, specifically on Zepbound, which is a GIP GLP-1 dual receptor, and has been shown to be more effective than just some of these GLP-1 receptor compounds, at both treating diabetes and diabetes and weight loss. These patients who are on these medications have shown significant intraocular pressure lowering. This is sort of a case by case basis. So it's unclear until we really are able to study this phenomenon. And Zepbound has not been on the market for quite for a very long time, so we may have to wait on that until we're able to actually study this phenomenon, whether this is sort of a generalizable effect. And if I heard you correctly, Cynthia, there was also some question about diabetic retinopathy. Is that right? So I think
Yes.
the data on that is relatively mixed. I'm not a retina specialist, but it has been shown that sort of rapid normalization of blood glucose in patients with diabetes can cause worsening proliferative diabetic retinopathy. And they think that is the mechanism behind which drugs like GLP-1 receptor agonists and Zepbound may result in worsening diabetic retinopathy. However, database studies have had mixed results. Some have shown that there is worsening, and others have shown that there isn't worsening. So it really remains to be seen there.
Yeah, that's really interesting. The next question has more to do with progression versus incidence. So it does seem like a lot, and this goes back to the animal studies you were just talking about. It seems like a lot of the published work is talking about the incidence of POAG, but for patients with established POAG, is there any evidence to suggest that a GLP-1 receptor agonist will delay progression? And how would that be measured?
Yeah, so as I mentioned, we're working on that right now, right? In
Mhm.
order to look at progression, we need testing data, right? And there is not a lot of databases. I mean, there are some out there, but we're trying to combine various databases with longitudinal visual field and OCT data for patients to allow us to look at progression, before and after they've been put on these GLP-1 receptor agonists versus something else. So there is not concrete data right now to suggest that GLP-1 receptor agonists actually reduces progression. We're hoping to look at that and answer that question shortly.
Great. Would you be able to access the or utilize the AAO NIH IRIS database to look at some of that, look for some of that information?
Yeah, so that is a possibility. I'm not very familiar with that database, but my understanding is there is not very concrete visual field and OCT data within that database.
I
If
see.
that's the case, then we still are missing some of these progression, indicators that we need in order to fully answer that question.
Okay. Out of curiosity, if you had a patient with a very dense cataract who couldn't undergo glaucoma surgery approach you and say, Dr. Q, would a GLP-1 receptor agonist possibly be a non-surgical option for someone like me who can't undergo glaucoma surgery? What would you say?
Um, Yeah, I mean, I think there's a lot of stipulations to that question. Number one, it really depends on whether there are other treatment options that are proven that are available. Is it possible to do something else to treat the glaucoma other than just surgical options? And
Sure.
really trying to figure out, why is it that surgical options are not possible? All surgical options are not possible. Assuming that it is the case that we just can't do surgery, At this point, I do not know if there's enough data to suggest that GLP-1 receptor agonist is going to decrease glaucoma progression. So this goes back to the idea of it decreases incidence, but does it decrease progression? That's what we're doing this study to find out.
Right. Um, so talk very briefly, if you don't mind, about the clinical trial process, because we've got a few questions about when could we expect to see some of those clinical results from your trial? How does this work?
Yeah, yeah. So one of the issues with clinical trial is it's an expensive process, unfortunately, right? So we need to, right, we need to get funding for the trial. Um, and, I think that's one of sort of the roadblocks here. We're trying to find funding for the trial. Once funding is solidified, I think we have enough um, public buy-in, from patients and people who know about GLP-1 receptor agonists, and also buy-in from ophthalmologists who've been asking me personally a lot of questions about this class of medication to go ahead and do the trial now. So
Mhm.
really the roadblock is finding funding and trying to, get enough uh, support to sort of support the personnel that we need to do the trial themselves.
It's always money, isn't it?
In
But
some
once you get
cases.
going, so how can the glaucoma community and us at GRF stay involved or updated on any possible clinical trials that you're doing?
Yeah, I mean, I will certainly keep GRF updated on that. No
Mhm.
questions there. And once we start recruiting, there's going to be a lot of flyers and sort of just announcements to help us recruit. That's really how we sort of get the word out, right? So, for clinical trials, it's very important to recruit the necessary number of patients that we've estimated um, to to make sure the trial is sufficiently powered. And because that's the case, we will be absolutely disseminating all this information, and I'll make sure I let GRF know about that. So anybody who's interested and may qualify can certainly reach out to us and our trial organizers.
Wonderful. Wonderful. This is a really interesting question. And if I go back 10, 15 years, something that I tried to chase down in my own research, but is there evidence of a connection between sugar intake and intraocular pressure?
That's a good question. Um, And I'm not aware of any studies off the top of my mind that has looked at that, provide evidence for that. To take a step back from that, the question may be, is there any suggestion that patients with diabetes and uncontrolled blood sugar may have elevated intraocular pressure? And I don't believe that to be the case. Um, in some of these clinical trials or some of these studies have looked at diabetic patients and their risk for glaucoma.
And that's the hard part with studying different diseases of aging, that there's correlation and causation, and it's really difficult to tease out one from the other.
Yeah, absolutely. And the retrospective databases, the studies that we've already talked about are really powerful because it sort of help us to figure out, okay, there's a connection here. We need to chase that down. But ultimately, prospective trials is what we need to really establish causation and effectiveness.
Absolutely. Please feel free to continue adding more questions. We're getting close to the end here, so if you have any burning questions, please put them in the chat. But a patient wants to know, how close are we? And seems like a very leading question to the Glaucoma Research Foundation, but how close are we to treatments that can restore or improve severe vision loss due to glaucoma?
So I don't know if I'm qualified to answer. That's a big question, and I'm not certain I'm qualified to answer all of that question. I know Glaucoma Research Foundation is working very, very hard and has been for many years to find a cure for glaucoma, right? So that is certainly the goal. My little part is just looking at one class of medication that seems very promising and see if we can sort of add that medication to the pile of potential new treatments for glaucoma. So that's kind of where I come
Yes.
in, but I leave the hard work to you guys.
Well, one little piece of the puzzle can make all the
That's
difference. Uh, And I would encourage the person who asked this question to please go onto our website, glaucoma.org. We have a lot of articles about very interesting research like Dr. Q's, and you can learn about our Catalyst for a Cure and the new Treatment Accelerator Fund. So we do have information there as well. One question that I had that as you were talking, what is is it what you've mentioned that in the very beginning that Adriana DiPolo, who's a friend of GRF's, research
yeah.
shows a protective effect of insulin.
Mhm.
How would that research differ from the GLP-1 receptor agonist research, either mechanistically or any other ways that you can think of?
Yeah, so mechanistically, it may not be that different in the sense that we know GLP-1 receptor agonist is an incretin mimetic, so it mimics an incretin hormone, which is GLP-1. And it's
Mm.
called the incretin hormone because its mechanism of action is to stimulate insulin secretion in response to oral glucose ingestion. So it increases the amount of insulin that is circulating throughout the body. So if insulin is neuroprotective, as Adriana, Dr. DiPolo's work has shown, then by increasing insulin within the body and presumably, the central nervous system and around the eye, within the eye, that can potentially result in a beneficial effect. So from that pathway, it may not be that different. Certainly she showed definitively that topical insulin, just putting insulin drops on the eye was protective. So this is, something very new. Until she showed it, I don't think anybody really thought that could be the case. And that has generated a, complete research avenue through which just putting topical insulin on the eye. So it may be that GLP-1 receptor agonists come at that from a different way by generating insulin secretion within the body. So not just directly putting insulin onto the eye. As I've shown, GLP-1 receptor agonist also has other mechanisms of action, right? And so some of these remain relatively unexplored, actually. One of which is it increases mitochondrial health. So it actually increases mitochondrial health. So there may be a connection there as well, and that remains unexplored.
That is very interesting. Given Catalyst for a Cure's interest in mitochondrial health,
Yeah.
moving forward, that may or may not be a topic that becomes more interesting to GRF, and I've been doing a little literature search on that myself. So that's very, very interesting. Thank you, Dr. Q. Do you have any closing remarks for patients, donors who are on this call? Who are listening in?
Yeah. I mean, once again, thank you for having me. And I just want to say, the work that GRF is doing, it's so crucial to our research, to everybody's research, and really just providing additional understanding towards glaucoma mechanisms and also sort of generating new cures. Without the support of GRF a few years ago, I don't think I will be where I am now. So some seed money from GRF to sort of fund new innovative research could go a long way towards us eventually finding a cure for glaucoma. So thank you so much.
Oh, thank you. To stay in touch with everything that's happening here at GRF, I encourage everybody to subscribe to Gleams and the eGleams monthly newsletter. Uh, this month's newsletter just came out today, featuring the Catalyst for a Cure dual meeting that we had with both teams in Boston. Um, I'm totally biased. I wrote that article. I think it's pretty good about how interesting that meeting was. A very comprehensive discussion between the two teams and parallels between neurodegenerative diseases and glaucoma. So really interesting stuff. I encourage you to subscribe and learn more about our Catalyst for a Cure initiative and the Boston meeting. Next summer, for you glaucoma patients, we are planning our next GRF Patient Summit in San Francisco. So we encourage any interested parties to consider joining us for that. And with that, I just want to thank Dr. Qi again for being here today, and thank all of you for taking the time out of your day to be with us and for asking such wonderful questions. And I just want to remind everyone that this important research is made possible through programs like the Schaefer Grants, which are sponsored by us. And these programs exist thanks to the generosity of you, our donors. We thank you always. And we continue to rely on your support to advance breakthroughs in glaucoma care. So thank you once again for being here today and for standing with us in our bold vision of a future free from glaucoma. Because of your unwavering support, the cure is truly in sight.